services and systems that affect them. And we'd like to really explore how we can all support that meaningful engagement in the work that we're doing. So we just have an overview of what the virtual dialogue agenda will be today. We'll delve into the WHO framework for meaningful engagement, which Maya Olsen from the World Health Organization will present, and then we'll have some experiences, some sharing on meaningful engagement in practice and what that looks like, and then we'll divide into breakout rooms to have a bit more of some ideas, creations, and some thinking about action items that we can do in the national and regional context to support the engagement of people with lived experience. And then we'll just finish off together again at the end to discuss or to share what was discussed in those breakout rooms as well. So I've got just a couple of housekeeping points. I'm sure you're all familiar with this by now, but please do keep your microphone muted unless you are speaking. If your connection allows for camera, then we'd love for you to be able to be on camera with us. And please do make full use of the chat and put any of your questions in. We will have time for Q&A today as well. And then just to note so that you're aware, this virtual dialogue is being recorded. So I'm going to start by just giving a quick snapshot of the UICC membership and some of our opportunities we have related to supporting the cancer community. So this is kind of a snapshot of the UICC membership base, and actually of our over 1,100 organizations, 40% of them are patient-focused organizations. That's really a large basis of who we're working with. And then by supporting the cancer community, we have a number of tailored programs that we do within the capacity building team. And the engagement of people with lived experiences really runs as a thread through all of these
you know how to use it better
programs.
I'm glad you're getting to use.
There we go. So this thread of engaging people with lived experience, as I said, runs through many of these programs, but I will just focus briefly today on the online learning piece and the patient engagement piece, and then I'll speak about some of our events that may be interesting to you as well. So on our online learning, this is led by a colleague that you'll hear from soon, Alessandro. We have a number of dedicated tracks of courses and resources on patient engagement. So we've included some of those here. And as you can see, that is over 16 hours of presentations available for free to the UICC members. We also have other topics on the online learning platform, but we've just pulled these ones out for you today. And then we have the patient group mentoring program, and the focus of this program is really to support and create tailored mentoring opportunities for patient groups. And we're working currently in the APAC, EMRO, and AFRO region. So the way we do that is increasing this peer support in collaborations, maximizing their representation in regional and global events, which again, I'll talk about in a second, and then creating tailored opportunities and mentorship kind of activities for them as well. And then obviously expanding their networks where we can to introduce them and to build relationships with the broader stakeholder community. This is just a quick overview of our groups at the moment. So we're currently working with 28 organizations across EMRO, APAC, and AFRO. The AFRO region is one that we have started this year, so we're really excited about that. And we actually have a couple, or more than a couple, of our organizations with us on this call today. The call for applications is open all year round, and we kind of recruit as and when there are spaces available. And Lua will actually share a link in the chat here, just so you have it. And if you know of anyone who could be a nice fit for this program, who is working in these regions and might like to join us, then please do share the link, and we'd be happy to have a conversation with them. And then this is actually one of our patient groups. It's a quote from Karen Nakawala, who's from Teal Sisters in Zambia. And I just thought this was a really nice one to pull out, because she talks about survivors being the best ambassadors that we have, and the need to equip survivors to become agents of change. So with that in mind, I will just touch on some of the events and activities we have. So UICC organizes the World Cancer Congress every other year, and this year it will be in Geneva in September. We also organize the World Cancer Leaders Summit, and you can see here on the right-hand side just some examples of how we are increasingly integrating the meaningful engagement of people living with cancer in some of the events we have. We also have World Cancer Day, and this year and in previous years, we've also supported the organizations in the patient group mentoring program through grants to actually organize kind of key events or campaigns around World Cancer Day as well. And this year for the World Cancer Congress, we have a specific theme. There are 6 themes. We have one specifically on people living with cancer. So we're really looking forward to seeing how the program for that develops. And if you are interested in learning more about the Congress, the program, or registering as well, then you can follow the link here, World Cancer Congress. Lua will also put that in the chat so that you have it readily available. And then the last event I just want to talk about is a workshop that we have after the Congress this year. So this will take place on the 19th of September. It will be in person, and it will be open to anyone who is a Congress delegate. So this is a workshop that follows on really nicely from this initial virtual dialogue, where we'll talk a little bit more about the WHO framework, and we'll really think about some of the existing or upcoming initiatives that support meaningful engagement, thinking about some stories and some lessons learned, what's worked, what's an obstacle, and then we'll have dedicated breakout sessions, again, in person, to really think about some concrete actions to support the framework and strengthening connections and collaborations through that meeting. So again, we've got the link here. Lua will also share it in the chat so that you have it readily available. And if you're interested, we just encourage you to register your interest, because there will be limited spaces available. So with that, I'm going to hand over to Maya Olsen. Maya Olsen is a lived experience advocate consulting for the World Health Organization, and she provides technical support to their lived experience workstream. So she's going to speak to us today about the WHO framework, which I know many of you are really keen to hear more about. So with that, I will hand over to her. And at the end of the presentation, we'll have about 10 minutes available for Q&A with her as well.
Thank you, Roseanne. And I am going to share some slides. Just get this up and ready to go. Okay, so as Roseanne mentioned, my name is Maya. I am a technical consultant on the WHO Global Coordination Mechanism for the prevention and control of NCDs, and I support our meaningful engagement work stream. I am also a cancer survivor and someone living with a severe immune disorder. I had been on the civil society end of things for many years, both around some of the challenges in my own country with such a chaotic and inequitable health system. But the work that I've really cared about is advancing the NCD agenda within the global work at the WHO and UN level, and also around capacity building and leadership development. I've worked with a lot of networks of people living with severe NCDs to really kind of build the momentum in lived experience advocacy. And so it was really exciting to be involved in the development of the WHO framework from my vantage point in civil society at the time, and then to be now on the team working on moving this forward within WHO and in collaboration with many multi-stakeholder partnerships and lived experience communities. For those that are not super familiar with the framework, the WHO framework for meaningful engagement of people living with non-communicable diseases, mental health, and neurological conditions is a technical and normative document framework. It's a product that was developed by WHO through a 3-year co-created process with over 700 people, most of whom had lived experience across different patient communities. It was a really participatory process that really allowed across all of the WHO regions an opportunity for people with lived experience to lay out the challenges and issues and priorities that they cared the most about. And the document is centered in the right to participate as an essential part of the right to health, and that social justice rights-based approach is baked in throughout the document. It's a big piece of work. It's a big document. The first half is really around the why of meaningful engagement, and there's a lot around kind of what meaningful engagement it allows moving forward in terms of more equitable rights and policies and programs within health. The second part of the document gets into some of the principles and enablers of what needs to be upheld to allow these equitable participatory processes to move forward. There are a number of principles that underpin the framework around dignity and respect, power and equity, inclusivity, intersectionality, commitment and transparency, and really institutionalization, but also fitting things to the context, to people's context. It's not a one-size-fits-all document. The recommendations, the principles and the enablers are really meant to be adaptable depending on regional priorities and specific community contexts. The enablers lay out a little bit more of a framework in terms of how to move forward meaningful engagement and to have more of the principles integrated into the ways that WHO and member states are developing and implementing policies and programs. But we've also seen it be a reference point for civil society organizations and for stakeholders outside of the WHO universe. In the document, there's also a number of recommended actions that were put forward across the 6 different enablers, and helping member states and WHO think about that in a bronze, silver, and gold kind of a gradation of kind of moving across, knowing that this is a sort of long-term goal, long-term work, and regardless of the starting point, there are real steps forward that you can make to continue to move towards the gold standard that we would expect, and we're trying to move towards within WHO. There's work ahead across all of the enablers and various challenges that we run into, but I think it was an exciting show of leadership from the lived experience community and commitment from WHO to really try to embed this within the way that the organization works and the way that member states and ministries of health are conducting their work. I skipped over this slide, but kind of where we are in the process. The first square, the first diamond on this was the consultation process. We spent a lot of time listening and learning that we're not, that doesn't stop with the development of the framework, but it was really about mapping and co-creating the initial document. Last year in May, we launched the framework. I'll drop links in once I'm done with my presentation for people to be able to find it. And now we are excited to be squarely in the second part of this diagram, where we are continuing to build on the evidence base, where there are various efforts around implementation, which I'll talk a little bit more about. And we're building a community around this through the Global Symposium on Meaningful Engagement, which I'll spend some time on as well. I think as we're going to be focusing on some of the enablers in the discussion around sustainable financing, really what are the kind of financial commitments we should be making to ensure that that people with lived experience are respected and this work is sustainable, redistributing power around all of the dynamics and what's needed to create safe and actionable spaces that really sort of respect and elevate the leadership of people with lived experience in an equitable way. And we'll also be talking about integrated approaches. How do you navigate this across and really leverage movement forward across different communities and health areas priorities? Any of the 6 enablers as well as the principles, they're all so interconnected. And so as much as you can have an individual conversation about one of them and what's needed to move forward progress, everything really kind of builds on itself. And we found that really helpful as we've kind of moved this to work with member states, but then the bronze, silver, and gold, kind of thinking about progress forward and developing action plans has also been a component that has really resonated. One of the things that we're doing globally to move forward from the framework into a much more concerted effort around implementation is we have recently launched the WHO Symposium on Meaningful Engagement, which I'm excited to see two of our steering committee members on the call with Aman Shannon and Carolyn Taylor. This is a platform within WHO that is looking at advancing the greater involvement of people with lived experience within the preparatory process for the next high-level meeting, the fourth high-level meeting on NCDs in September of 2025. But it also is a more open-ended opportunity beyond that to really build on knowledge exchange and co-design, and to develop and further some of the targeted recommendations for member states in terms of how to operationalize the framework, and what that roadmap should look like. We just had the first symposium last week, which went off with a bang. We had about 350 people join us over the 2 days. We had some really in-depth discussions about next steps and priority setting. I know I saw on the participant list a couple of people that joined us last week, but the point I want to make with the timeline is it's a full 18-month process. And so we got so many great ideas and inputs from the lived experience community in the first introductory symposium. The steering committee and our team is coming together to develop an advocacy strategy and action plan, again, both for the fourth high-level meeting, but also for some of these more general goals around next steps. And then there will be further touch points and symposium opportunities for everyone to come together, and activities happening kind of in the interim between those periods. So think about it as a process and as a platform. It's a very dynamic timeline that there will be these touch points around meetings, but it's much more than that as well. The symposium has been fully led, co-designed, supported by lived experience leadership. We have a steering committee that was selected in the spring and has already done some incredible work to move us through the first symposium. We also have kind of additional folks in the community who are providing advisory support and are interested in getting involved in that co-design with the steering committee. But we're working on this all together, and there's still work to do with the steering committee to build out broader strategies for diverse and inclusive engagement throughout that timeline. And so there will be much more to come from us on that. The two main goals with the symposium I already mentioned, people can take a look at these slides afterwards. One is around the UN fourth high-level meeting preparatory process, and really being much more strategic and much more intentional of the ways that people with lived experience can be involved in certainly the dialogues and meetings that underpin this sort of negotiation process, but also have a more organized platform within WHO to provide those key messages to member states and to be in conversation with some of the policymakers through the negotiation process. Alongside that, we're thinking more broadly about the ways in which knowledge exchange and the community can come together around recommendations for implementation. There's been a lot of commitments recently around meaningful engagement and meaningful participation, but the next step is to really collectively mobilize around what does that look like? What input and guidance and support do member states need? What do civil society communities and lived experience communities need as far as capacity building and to be able to build on that agenda together? I think I already mentioned this for the most part, but again, just a quick snapshot of what the timeline is looking like for the next 18 months and some of the goals along that timeline. We'll also, in between those larger meeting touch points, we are going to try to be hosting a lot of the conversation and dialogue with the steering committee onto the Knowledge Action Portal. And so I'll give a link to sign up for this. It's not live yet. We're still doing a little bit of internal work, but it will be an opportunity to have an online platform to be in conversation with us and the steering committee as we move forward, and a great place to go for updates and ways to get involved. Specific to cancer and kind of thinking about implementation at member state and regional level, I did want to highlight some really important work that's happening in the EMRA region. There is a funded pilot project ongoing on implementing the WHO framework in 6 member states in the EMRA region. A lot of the work right now is in a scoping stage and really sort of country selection and that part of the process. So very soon we'll have much more opportunity for communities, advocates, communities, and stakeholder organizations to get involved in the participatory process. We're kind of in the middle of scoping, review, country selection, stakeholder mapping, and then there will be multi-stakeholder dialogues happening at the country level, led, supported, inclusive of people with lived experience to really better develop a needs assessment and action plan for each region to take forward around meaningful engagement and the ways in which each of those member states and countries will move forward on the recommendations of the framework. So we're excited for that, for the EMRA region and the leadership there, but we also think that this could be a model, a pilot that is really relevant and for other countries, other regions to move forward. And we're seeing that work continue also through civil society. There's been exciting work happening in India and Nepal around directly bringing the framework to policy setting and to policymakers in those regions as well. And so I think it's not a one size fits all. There's a lot of opportunity to move forward on the framework, and we're excited to support and collaborate with that across stakeholders. We also, there's been a lot of work to really build the evidence base around meaningful engagement and to better understand the opportunities, the results, what impact meaningful engagement has on health outcomes, on more inclusive processes. We've had an intention to action series ongoing. There's a couple of reports out, which I will drop links into in a few to start to get into some of these, thinking about this regionally in terms of regional priorities, sharing some of the perspectives of the lived experience community. We've been working on some pieces recently around promising practices of implementing meaningful engagement and to show some of the different ideas and examples of great projects that have gotten into some of these challenges around implementation. We have also some academic publications underway, including a special collection with the BMJ where we have 7 lived experience first authors who are writing pieces under this collection, cancer of which is highlighted through a South African colleague and expert. And then we're doing a lot of internal work to walk the talk and to provide more formal opportunities, sustainable, compensated opportunities for lived experience to join us as experts alongside any other type of technical expertise. And that gets complicated and challenging, and WHO is not a simple organization to shift administrative processes within, but we've had a lot of early success in that and learning a lot on places that will continue to be challenges we'll need to work through. I want to have time for Q&A, but the last sort of plug I wanted to give is with the high-level meeting timeline and the work of the symposium, I did want to, and I realize this is an old slide, June 3rd. It's not 26th of May. I'll drop this into the chat. We have consultations within WHO open until June 3rd that are in preparation for the International Dialogue on Sustainable Financing for NCDs and Mental Health later this month, as well as input into the WHO Director General's report for the 4th high-level meeting, which is a seminal document for WHO to really lay out the way that we within the organization are seeing the priorities for the outcomes for the high-level meeting. But it does also become a touch point and a reference document for member states as they move into negotiations. So it really is, they're two very important opportunities to provide input at the organizational level as well as the lived experience level. So I will drop those links in and do encourage you to take advantage of them. There's a lot of momentum happening at WHA next week around the resolution on social participation. Please do take a look at the community for meaningful engagement as we get that live and launched, and you can join now. I won't let you in until we have everything up and ready to go. But there's also, for people particularly interested in implementation and innovations and some of the knowledge exchange around work happening on the ground. One of the initiatives that we do is the NCD Lab, which is seeding innovative projects across regions, of which women in NCDs, youth leadership, and meaningful engagement have been the 3 pillars of that work, and that's so relevant to the leadership and the cancer community and people affected by cancer. So I will stop there.
Thank you, Maya. Thank you so much. And I think it's just a note maybe on the EMRO pilot that you talked about. So that is another piece that will be focused on at the World Cancer Congress, and will be a nice link over to the workshop that I also just talked about. So yes, we do encourage you, if you were going to the Congress, to also think about that session. So I think we've got about 5 slightly more minutes for questions. So this is really an open kind of workshop. It's not webinar format, so you can just raise your hand and unmute yourself and ask any questions you may have. If you prefer to write in the chat, you're also welcome to do that. Any questions? Alessandro, you unmuted yourself.
Maybe while our participants take the courage, maybe a very quick one for Maya, Alessandro from UICC here. Given your experience in driving this agenda across the NCDs and mental health conditions, do you see any difference in any of these spaces where a particular group of advocates on a particular disease are more advanced, are better examples, and how do they compare? How does cancer sit in there?
It's a good question. I think there's definitely communities that have been able to mobilize and bigger have a little bit further along in mobilization. I would put sort of the cancer community, the diabetes community that have really kind of had running platforms for a while, have done a lot of work in this space. That being said, I think one of the things that the framework does really nicely is take us out of that sort of those kind of vertical pillars, because I think with lived experience, those of us who are affected by cancer are probably also living with a couple of other things. There's a lot of fluidity in the way that our own identities are, and the issues and lived experience that center our work. But I also think that the sort of, there are specific issues within cancer, within obesity, or within sickle cell disease that are particular to the experience and the clinical challenges and personal challenges. But the overall principles and the overall kind of the ways in which navigating these conditions affect our lives, why we want to be more involved in the health systems that affect us, that is really cross-cutting. And we see this very, very similar challenges around stigma, around being tokenized. You know, you see those same things happening across the communities. So where you have a really strong effort already underway, like with the cancer community, I think what I'd really encourage is sort of understanding that and really looking at ways in which you can share lessons learned, or you can kind of be inclusive of some of the rarer conditions, communities that have struggled to find that space, if that makes sense.
Great, thank you, Maya. Rania, hello, you've got your hand up.
Yes, hi, and thank you so much for UICC for making this like more cozier group for the NCT, and thank you. And Maya, it's I'm proud of what you're doing, being like walking the walk, and being your skin in the game as a patient. My question actually before my question is like a quick comment about the vertical pillars, like for NCTs. Actually also an initiative done with the UICC elderly patients with cancer comorbidities are real, and that's why you cannot separate them. Diabetic, high blood pressure, heart disease with hand in hand with cancer can significantly decrease the some of the wins, I would say, that was done in cancer. And my question is like, if we recognize that these vertical factors or horizontal, whatever you call them, across regions, across ethnicity, across disease areas, how do you make sure that there's meaningful engagement? I recognize that symposium and platforms like this serve in that, but what practically can be more done? And I'm talking from a patient advocate point of view, like how can we support more? Thank you.
Yeah, no, it's a little bit of a balance, and this sort of horizontal versus vertical. I think I worked with Partners in Health, an organization, a civil society organization for years, and Paul Farmer would, who founded the organization, would always talk about the diagonal approach. Because I think there's places where really kind of sitting within the cancer community and really understanding what are the decision-making and the stakeholders and places for inclusion and engagement within the cancer community, whether it's sort of the work that you're doing with the UICC patient advocacy groups, or looking at the WHO, you know, UN level, Ministry of Health level policies and things that are on the decision-making tables specific to cancer. You can really bring to bear your lived experience, and I think kind of asked to be in those rooms, look for sort of look for the connections and trying to make those relationships with ministries of health specific to cancer. And that is really effective, and that can be very sort of it's a really good way to move the movement forward, so to speak. But then I think there is the sort of broadening out of kind of seeking community beyond just the cancer world, and really sort of the knowledge exchange and ways in which many different communities coming together, especially when it comes to kind of WHO, UN level advocacy, but also for a Ministry of Health. They don't always have the resources to be thinking, meeting with each individual community kind of lived experience level group. But if you come together and kind of as a coalition demand their time in force across many communities, that can be more powerful. And so I think just having an eye on both vertical and horizontal, and be thinking about things kind of across in more of a diagonal fashion. I'm going to steal Paul's words there, but did I answer your question, or were you looking for more there?
Yes and no. To be perfectly honest, maybe to make it like more solid, the question is one of the tracks actually in the symposium and now is institutionalizing engagement. So recognizing that at the local, regional, or global level, we do things that can overlap and will overlap because we are addressing the same thing, but just in different geographical or groups. Institutionalizing it requires that we collaborate and on a sustainable way, because that gives us more magnifying our impact. like not just to be an initiative once in a while and then we move to the next thing. It's a never-ending cause. So I wonder how we can do that. And I think this is not to put it all on you. That's our everyone question. Thank
Yeah,
you.
it's a really good question. And I think the institutionalizing engagement enabler is, it's a great one because there are very sort of specific things that institutions can do. They can look at the way that they are developing their timelines and kind of moving from one-off engagements to developing kind of a mechanism like the symposium, thinking about, I spend a lot of time, and Joanna and some of the folks on this call know, I spent a lot of time within WHO just sorting out how we are going to set up contracts with people with lived experience like we would with any other academic expert. And that is internal and messy, and it has to do with our HR departments and our legal departments, and like those sorts of things are essential to be able to move this forward. I think the question you're really asking is sort of how do we work across someone like you as a community advocate versus someone kind of within one of those institutions in a transparent and meaningful way to push that agenda forward. We sort of sit behind our veil because we know it's complicated and we don't want to burden people with all of the little things that we're doing, but maybe we can be more transparent of these are the wins that we're making on institutionalizing things within WHO. These are the things that are really challenging. Keep pushing us, keep staying in conversation about what we are and aren't able to do. And we can kind of do this together. We do that one-on-one with kind of advocates we're bringing onto contract with, and they see a little bit more about the challenges we're having internally around institutionalizing things, but maybe there's a better way to kind of be in conversation around that. And I think that transparency you don't always see at Ministry of Health level or with larger organizations. And so I don't know that I have a solution there, but I really like the way that you're thinking about things, and let's keep working on it together.
Thank you, Maya. And I think it's a great kind of
Hello.
over
Hello.
as well. Hello. So I think we are going to move on now to the interview because we are limited in time, and Kate has been very kind and staying up very late for us in New Zealand.
Can I speak? Hello? Can I
Hi,
speak?
Vivian, we're just going to move on to the interview part, but then we'll have a breakout room soon with more discussion on some of these enablers, if that's okay. We're a little bit over time. But if you want to put your question in the chat as well, then I think Maya will be able to respond to it there as well. So with that, I am going to hand over to my colleague Alessandro, who you met earlier, and he will be having a discussion with some of the young leaders he works with through the Young Leaders Program. So that's Amanda Drury from Dublin City University in Ireland and Kate Meerkirk from Te Watu Ora Waikato in New Zealand.
Thanks, Roseanne, and thanks, Maya, for the presentation. Thanks, everybody. It's lovely to see many leaders, patient advocates, and people who lived experience who probably do a much better job than me sitting here. I really approach this space from a place of humility and learning, as a bit what Maya was saying, and as Carolyn put in the chat, we can all learn how we can be better, become better advocate, and make space for people with lived experience. So I approach this conversation really from that space. How can UICC become better? How can I become a better advocate to that? But short on time, let's just go straight in. Thanks, Roseanne, for making a very quick presentation of our amazing health practitioners and researchers. They're going to share a few examples on meaningful experience in practice. Maybe we start really, and I'll start with you, maybe, Kate. I know it's very late in New Zealand. So what is your understanding of meaningful engagement in your work, and why it is important?
Thank you, Alexandro. And I just want to take a moment to acknowledge all the people with lived experience of cancer in the audience today, and just acknowledge my positionality as someone who hasn't gone through the journey of cancer, but who is privileged to work alongside people who are going through the journey to co-design services together to improve the experiences of those. Incorporating lived experience into service design just seems so intuitive in many levels, but it's really hard to implement. And I guess it would be really nice to put it in context of where I'm coming from. So New Zealand, as many of you know, is a tiny island nation of about 5 million people southeast of Australia. 15% of our population are Indigenous, Māori. And even though the makeup of the population is quite small, Māori, in terms of health outcomes, experience huge inequities. So Māori are 20% more likely to be diagnosed with cancer, but twice as more likely to die from cancer as non-Māori. And in fact, if we look at something like lung cancer, which is the biggest killer of Māori women, that in itself is the biggest contributor to the over 7-year life expectancy gap between Māori and non-Māori. So we focus on what's good for Māori and improving health equity outcomes for Māori, and we really prioritise that in the cancer space. And we like to say what's good for Māori is good for everybody, because we're currently working with a service delivery model designed in England hundreds of years ago, which doesn't necessarily take into account the complexities of modern living. So our engagement there, my experience especially, has been working with our Indigenous communities, and it's the second context is our constitutional document, Te Tiriti o Waitangi, guarantees Māori rights to health, but also participation. So self-determining how they receive healthcare is really important to us. So it's not only an ethical and moral obligation to incorporate people with lived experience into service design, but it's also a constitutional right. I'll stop there and
Thank you, Kate. So this, Amanda, what about you? You base their understanding of the meaningful engagement also on a rights-based approach. What does it mean and why is it important in your context?
I suppose I'm coming from a research, and I work across research and policy with very different hats on in each context. I suppose coming from a research perspective, and I suppose I'll say this first, I'm a cancer nurse. I have no personal experience of having lived with cancer, but certainly I've had experience of family members who've lived with cancer. And I think coming at this as a researcher and as a nurse, fundamentally, my professional values are that everything we do has to be driven by the person with lived experience. We cannot design a health service, as Kate has just outlined, without thinking about the person who is the end user and how they will navigate that service, how they will experience that service. I suppose much of my research looks at how does our health services impact on quality of life outcomes, which is one of the most important outcomes for anyone who has lived experience. So when we look at designing research, there is no point in healthcare professionals and researchers and people without lived experience driving this agenda. So we need to work together, work with people with lived experience, and really take the privilege that we have to work in the arena that we do to advocate for those priorities that are most important to people with lived experience. I think then on the converse side, coming from a policy perspective, it's really about trying to enshrine those rights in place so that we can create the infrastructure, create the drive, and create the need for anyone who is in this position to have influence to actually drive their work based on those experiences of people who have lived through cancer. And I suppose I'm keeping it quite concise because I could go on for hours, but I suppose if there's anything else you want me to clarify, I'm very happy to do so.
Thank you, Amanda. We'll have time to jump and dive through and ask you for a bit more details, but maybe going back to Kate, you mentioned a little bit your work with the Maori populations to address this inequity. Can you tell us a little bit more about an example about using really meaningful engagement in practice to address those inequities that you mentioned?
I can give two quick examples if that's okay. One which I'm really proud of because it's still going. I think about 10 years ago, we started working with the population for breast screening, recognizing that our breast screening program was not equitably screening women of different ethnicities. And we looked at especially working with recent migrant groups. We're a small Pacific country with lots of Pacific Island communities coming in and out. And with that, we were able to demonstrate quick wins for our board. And I think that's quite important when we're starting to introduce working with patients with or people with lived experience into our service design, is to demonstrate something that's really intuitively understandable. Like, we booked people who spoke the same languages together. We picked them up in a bus from a culturally safe location like a church or a community center, made the waiting room very friendly with music, with food, with staff that spoke the language. And so we made it a very comfortable experience, and we managed to screen those women and get those numbers up on the board to demonstrate our efficacy. But I think the bigger success for me was all the learnings that we took away, which was the fact that actually saying the word cancer is taboo in a lot of communities. I mean, people thought that was manifesting cancer. So in terms of screening, we had to completely change our language. We had to completely change our schedule. This arbitrarily set deadline by our board wasn't going to fit the community's needs. And we also had to spend a lot of time building the trust of those communities, because actually this community was labeled a problematic, hard to reach community, a naughty community, that previously people had engaged with a lot in these ad nauseum consultations and then gone away with their IP, with their intellectual property, developed these solutions that didn't really fit them, and then had those solutions imposed on them in the past. So when we came to work with them, they actually sort of said to us, why should we work with you? Why should we give up our valuable time? And I was really heartened to read in the WHO framework, the remuneration for people with lived experience. But why should we spend our valuable time and resources helping you when actually in the past you haven't done anything for us? So that's been a continuous learning journey, and that's still going today, which I'm really proud of. And in the Waikato, I know we're trying to replicate that model for the Tokolauan community and the Kiribati community. So I'm really proud of that. And then perhaps later I'll mention the lung screening work.
Thank you, Kate. So really looking at service is really taking, as a first step, I would say, taking the user-centered approach, ensuring that whatever you design is fit for purpose, but also that the consultation for the consultation's sake, it doesn't work, where it's more an issue about co-designing, really, in that sense. Amanda, I know your work is more on the research side or on the policy side. Can you tell us a little bit more practical examples of engaging those with lived experience on those arenas?
So I suppose, again, and coming back to groups who are at risk of marginalisation, I suppose Ireland is quite Ireland and the UK, I think, have had a very positive culture towards patient. We call it patient and public involvement typically, but it's the same principle of engagement. So in Ireland, about 4 years ago now, there was a very significant investment from our national funding bodies in developing a network for patient and public involvement. So it's called PPI Ignite. So the role of this network, and I'm a site co-lead at DCU, the role of this network is essentially to implement strategies, policies, resources, essentially, that will drive patient engagement. I suppose this is where I loved Rania's comments earlier, because institutionalization is always it has such negative connotations in my context. And to hear this idea of it being so positively framed, that we're going to institutionalize this very positive effort. So I suppose the idea behind PPI Ignite was to make patient involvement in research an absolute basic standard. We've seen a huge movement in our national funders over the last 10 years that if you are putting in a research funding application, you have to show evidence that you've engaged with the community of people with lived experience who are going to be the participants of your study as much as they should be co-researchers in your study. So they're involved in deciding what is the research, how is it going to be done, and who will it be done with. So there's been a lot of work done in terms of remuneration standards, and one of the challenges here is that for somebody who may have a long-term chronic condition who is reliant on social welfare, that they may not be able to receive physical remuneration, so payment for their engagement. So what they've tried to do is look at how can we overcome these challenges. So what are alternative means of remunerating people? And certainly it's been very much driven by engagement with the community. Other things are developing kind of standards around ethical engagement with people with lived experience. And we've seen really positive work coming through, particularly with children and adolescent people who have lived experiences of chronic conditions, not necessarily cancer. So I suppose these are things that have had a very positive impact on the culture around engagement of people with lived experience within research in Ireland. I suppose in the policy context, I'm a member of the European Cancer Mission Board, and for those who aren't familiar with it, it's tasked with driving the research and innovation agenda within the Horizons Europe. And so one of the key pieces of work that the Cancer Mission has driven has been an engagement with adolescent and young adult cancer survivors. And what this has actually led to, that we've had 4 consultations over the last year. And what this has resulted in was that the representation of a funding stream within the work programme for the Cancer Mission that responded directly to the needs that were identified by adolescent and young adult cancer survivors. But alongside this, it's led to a number of events with adolescent and young adult cancer survivors who have driven what the agenda of those meetings have been, and really raising awareness of the issues that are there. So I suppose, again, Maya's presentation on the framework and the next steps are, how do we go about implementing it? Really what the next steps for the Cancer Mission is, how do we sustain it? How do we maintain that engagement with this community and really leverage what has been achieved so well within a 12-month period to really have impact in the next stage?
Thank you, Amanda. So what I gather again is it's not just engagement, but an important part is the meaningful part, and to add to that, the sort of the ethical, meaningful and ethical engagement. So be curious to know what those principles that come out from your work in Ireland. Conscious of time, and maybe I want to also allow anybody who wants to ask a question, put them in the chat. But just a couple of final wrap-up questions for you two. So from your experience, from what work you've done, whether in developing services, policies of research with the engagement and the meaningful engagement of people with lived experience, what are the success factors and what are the main barriers that you have encountered? Kate, maybe we start with you.
I'll try to limit to 3. And flip sides of a coin, so challenges could also be opportunities. I think I really love what Amanda said about letting the people with lived experience set the agenda, the youth. So in New Zealand, we've just switched from pap smears to HPV screening for cervical cancer. And when we engage with the communities about, well, how do we increase uptake of this? They're actually talking about generational timelines. And they're more interested in how do we stop this from affecting our children of the next generation. So most of us work to 1-year budget cycles or 3 years if we're lucky, but actually switching our KPIs and switching our timelines that way. The second thing is about the remuneration. I think really investing in the community as well to upskill. So it's not just about how do we pay for that meeting, or how do we compensate for that time or the transport, but how do we do capacity building, capability building for the entire community, and treat that like a workforce pipeline exercise in terms of how do we actually invest into this community of people with lived experience so that we are able to learn from them and reciprocate going forward. And that could just be not just about service delivery principles, but about well, what is this meaning for? How does health funding work? Which is not apparent to most people. And we've even had to sit down with people and go through how to use IT. What's the difference between this governance group versus this operational management group? So I think that's really important. And then the third thing, especially working with this Māori community where cancer doesn't impact individuals per se, but actually families. So whānau is really important. So changing up our definition of what it means to be a person with lived experience, because that might be one day that person that we would perceive as a person with lived experience, but also their uncle who's their primary carer, or they might have a baby on board and we don't know, but letting really redistributing power and letting the people with lived experience decide for themselves.
Thank you, Kate. And it's a great point around the training and the support and investing in that community. Amanda, you work in the policy level, so you deal with institutions. What are the barriers and success factor? Did you find a lot of goodwill around the space on this agenda?
I think certainly what we saw in the cancer mission engagement process, there was huge enthusiasm, and I think it was just that opportunity to have a voice and to have a voice at that level for the people who were engaged. I suppose on the flip side of that, and this is something I'm always very conscious of because we're working in Europe, which has multiple languages, and that can often be a barrier to engagement. So a lot of the research I do works across Europe. So when we're talking about engaging communities, some of the biggest challenges can be either not being aware of those opportunities for the person with lived experience. So in my own research, I've worked a lot with older adults who are living with cancer, and what we wanted to do was we weren't seeing this group being engaged quite so well in research. So we thought we have to start at the start here. So we actually need to consult with them, understand what do they understand by patient and public involvement or meaningful engagement, and what did they see as being necessary in order for them to be engaged, and in parallel, what they felt was important for future research in this area. I think it was rather eye-opening because trying to recruit into the study, it was a small qualitative research study, but people who took part were doing it. It was very much gestures of goodwill, very altruistic motivations. And the first thing people would say is that I actually don't know. And I think this is often the challenge, is that, you know, we can't talk about meaningful engagement if we don't make it publicly accessible. So we have to stop talking like researchers, stop talking like policy makers. We have to actually make this accessible to the community, but we also have to make it translatable too, so that people who are coming from groups that are more at risk of being marginalized for whatever reason, or people who may not have English as a first language, when we work in a predominantly English speaking setting, that they do have opportunities to engage. And I think this is one of the biggest priorities, I think, for meaningful engagement, because cultures are different around what it means to engage, and we can't start to address those challenges until we actually are speaking the language of the person who wants to be engaged. So this would probably be where, rather than saying barrier, it's the priority for what we need to do now.
Thank you, Amanda. I'm conscious of time, so maybe I'm just looking at Roseanne now. If there is any quick questions for Kate or for Amanda, or a comment on their sharing of their perspectives around engagement to inform services, research and policies, we might have the time to take one. Just looking around the chat. There is a comment from Ikram about pointing that research is very useful. The research promotes patient empowerment and improves the likelihood of the study being important to patients. Thanks for that point. But unfortunately, disparities in accessing trials and research opportunities are a big obstacles in low and middle income countries. And thanks for that point, absolutely. And I think we'd be curious to know how we can drive better that inclusion in research in those more resource-stretched settings. In case there is no other question, maybe we should save the time to really get into the conversation in the breakout room. So I'm just going to take this chance to thank Amanda and Kate for their contribution. I know they need to jump to at the meeting or to the end of the day. It's very late for Kate in New Zealand. So thanks very much for sharing your perspective and your experience in this field.
Thank
Thank you.
you.
Thank you.
Thank you, Amanda and Kate, and thank you, Alessandro. So as Alessandro said, we will move on to the breakout rooms. So the way we have designed the breakout rooms is around 3 of the enablers, which you've heard about today. So I am going to share my screen so you can see what the breakout room themes are. Let me just pull that up. So Maya will be in one of the rooms. And then we also have Eman Shenan, who is one of our organizations from the Patient Group Mentoring Program. So she's the founder of Aid and Hope for Cancer Patients Care. She will lead the discussion on redistributing power. Maya will be in the room on sustainable financing. And we did have Karen Nakawala from Teal Sisters in Zambia, but unfortunately she wasn't able to join us. And Chris Cheng has very, very last minute kindly stepped in to facilitate the breakout discussion on integrated approaches. So that's why we don't have a photo of Chris Cheng, but he's from Cancer Survivors Malaysia. So the way this will work is Lua has set up the 3 breakout rooms, and then some of you in your registration, you could select which enabler you were interested in talking about. So that's where we've kind of taken these 3 from. And then, so you'll be able to click on your screen. There will be a box that shows you the breakout rooms, and you'll be able to select the one you want to go to. If that does not work, or if it doesn't appear on your screen, you can go down to the, I'm going to say bottom right corner. It could be top right, depending on how your screen's set up. And then you can click on breakout rooms, and you can also join that way. If both of those ways fail, Lua can put you into a breakout room, so you can message her in the chat, or you can stay in this room until some of the people have moved out, and she can help you there. So we'll have 20 minutes in the breakout rooms. We have some questions to discuss on the enablers. And then we really encourage you, obviously, to kind of share your ideas, share your opinions. And then we'll come back to the main session again and just have a bit of a debrief on some of the key kind of discussions and ideas and action items that have been shared. So we do encourage you in your breakout rooms to volunteer or to select a rapporteur who will be able to give that brief feedback. If you are happy to do that, please do volunteer. I know it's always a little bit tricky to find one, so we'll be grateful for anyone who volunteers for that role. And I think with that, Lua will add us to the room. So just as a reminder, you have redistributing power, integrated approaches, and sustainable finance. So welcome back. So we have 6 minutes left. So I'm not going to ask everyone to give their kind of opinion on what was discussed in the breakout rooms. I will just say I really liked in the breakout room I was in, it was Sandra, she mentioned, she said, we don't just want a voice, but also a vote, which I thought was really something that sticks in my mind. So thank you, Sandra, for mentioning that. That's something I'm going to come back to, I think. So I'm going to, I think, instead of calling on each breakout room, just really open it up. And obviously the facilitators of the breakout rooms, if you have anything you want to just talk about. I see Eman already with your hand up. Please go ahead.
Maybe we have 6 in our rooms or 7, Alessandro. And this is attract something in my mind. When you divided the main slogans for the break room, I think redistributing power didn't attract all the participants because it's a new terminology. And this shows us why our voice is not high and raised, because it's very important that when you are talking about it, changing the situation and getting the rights and fight for the people who are living with NCDs, everybody was looking for capacity building or financing or something like that. It's the first step to advocate is to redistributing the power, because we have exist platforms, exist bodies, dynamics, and everybody saying how we will change. No, we can't change. And this, how we know that we can change? In the past, I couldn't reach any UICC workshop and conferences or WHO, but I have to look, I have to search, I have to find ways how to be a part of this, even if I'm talking on behalf of thousands of women who live with cancer or cancer survivors. It's very important for the future to let the people know that their voices are precious, and a lot of values should be added through them. They should not give up. They didn't give up while fighting cancer. They have to continue their process in order to raise the voice. Thank you.
Thank you, Emma. And I think that's a really good point. And I think in our room too, we were in the integrated approaches room. I think maybe in a similar way, there's a little bit more familiarization that needs to happen with the WHO framework. Chris, I don't know if you want to add anything, but I think a bit of hesitancy at first to really kind of figure out what we're talking about. So maybe that links as well to what you were saying. Chris, do you want to add anything from our room?
Yes, from our room, I do notice that, yes, we're still not that familiar with, especially the various different terminologies out there. I can put up my hand and saying when I thought you were talking about sustainable financing, I was more thinking it was about the healthcare financing, not about the patient representative itself. But also, I've in our breakout room, I noticed that different countries are on a different spectrum in terms of where they are in terms of having patient representative, and how does I'm not sure how does the framework will address that. I do know that there's different level, bronze, silver, and gold. But would it affect the healthcare system of countries that are still further behind?
Thanks. So I think that's maybe a question for Maya to answer, and maybe at the same time you can just give us a quick summary of your room.
I was doing that in chat. I think that question came up in our group. The framework and the principles around the framework are very much targeted towards what will move forward meaningful engagement. And so sustainable financing with respect to meaningful engagement, how to think about power dynamics in terms of inclusion in development of policies and processes. That being said, I think one of the questions we were having in our group is in areas where there are really like basic needs that are being fought for in terms of financed, quality, accessible health systems. That's often the starting point. You're thinking about how to get care to people who need it. But I think that the challenge and the sort of call to action is how can people with lived experience and patients be at the forefront of that? What we don't want to see is, let's get to a functioning health system and then we can think about meaningful engagement and bringing people into the process. But how to do that, that's the challenge we all are facing. One of the things that our group really focused on is context is so different across communities, cultures, countries. And so the starting point for sustainable financing is very dependent on what's happening around you. And I think that's probably something that came up across the groups. But Priska, I don't know if you had anything. I saw your hand up. Is there anything you wanted to add on behalf of our group?
Yeah, I can add something. Thanks. I wanted to add something on the strategies, and I shared an experience in Kenya where the NCD Alliance of Kenya, they involve people with lived experiences in terms of giving them consultancies to do. Because within the lived experiences group, there are people who have professional skills and they are able to conduct some of these assignments. So if they can also be given assignments, they'll be given priority. Maybe it's a survey, or writing a paper, policy paper or something. They can also be able to conduct these activities. And so they should be thought of. And this will help a lot. There was also the issue of the challenges. I think challenges we cannot overemphasize. The issue of people not being well remunerated, and of course having disparities. So you have the people living with lived experiences, people with lived experiences, sorry, they are given less. If maybe it is transport or a per diem, they are given less, as opposed to the people working with the organizations convening the meetings, or even the experts. So you find that people with lived experiences are given less. So that disparity also is there. And I think it should not exist, because you all go to the workshops or you participate in activities as equals, and without having that sort of wall that this is a survivor and this is an expert. Yeah. Thank you.
Thank you, Priska. I think those are really nice. Well, not really nice because it's not great that those people are not so well remunerated, but I think really good examples and real life kind of examples of thinking about how we might want to change those and speak out and improve the way that we engage with people with lived experiences as experts. So I think we're going to wrap up now. We're just 1 minute over time. I do want to say thank you for your participation today. I hope you found it informative. I hope you found it inspirational, or you have an idea of something you can take away from today and move forward, or something you want to read. Maya sent many links in the chat. So we will also send a follow-up email and just pull all the different links that were shared together today so that you have access to them and you can read more on the evidence base. If you would like to just continue the discussion at all with UICC or with Maya, obviously, please don't hesitate to reach out to us. As Maya said, there's the symposium that is ongoing as well. So there are different opportunities to engage still. And we would love to see you as well at the Congress and the workshop that we're organizing. And just to finish, I would obviously like to thank our guest speakers and facilitators today. So thank you, Maya. Thank you to Kate and Amanda. Thank you to Eman and to Chris, and also to Alessandro and Lua, who's been running the meeting for us.
Thank you.